Good afternoon, everybody. I'll be talking on the guidelines for early detection and prevention of squinting eyes. I have no financial interest to disclose. As we all know, strabismus and amblyopia are one of the common eye problems seen in childhood, which lead to failure of development of binocular vision. This, in later years, prevents the children from pursuing certain occupations and has a lot of impact on social and psychological development due to cosmesis disfigurement. Therefore, we should have certain guidelines for timely detection of these cases so as to facilitate the surgical management in later years and prevent amblyopia. At presentation, in kids, the squint is generally seen in a newborn baby, which is intermittent and reduces by 2 to 4 months of age. In case you see a squint which is constant and fixed, or is intermittent, which is worsening over the last 2 months, should be referred to an ophthalmologist. The causative factors may be uncorrected refractive errors, organic disease like cataract, corneal ulcers or retinoblastoma, amblyopia, neurological diseases like cerebral palsy, craniofacial deformities, and in case of acute onset strabismus, we should always rule out intraocular tumors and other neurological disorders of vascular etiology. Pediatricians play a vital role at the first level, so they should be trained for basic eye examination and also direct ophthalmoscopy to see for red reflex. In case the child is premature or has any of the risk factors like low birth weight, increased use of oxygen in the NICU, family history of retinoblastoma, congenital cataracts or any metabolic diseases, infections during pregnancy, difficult or assisted labor with a low APGAR score, known central nervous system disorders like cerebral palsy or developmental delays should be referred immediately to the ophthalmologist. Pediatricians should also inform and counsel the parents about the common eye problems seen in children, and they should also notice themselves some unusual behavior like abnormal blinking of eyes, eye rubbing, abnormal head posture, any obvious squint, or if their child is watching television close to face, they should always take the child for eye examination. At school level, all children should undergo a medical examination and have regular school screening programs. It is the duty of the school teacher to inform the parents in case they notice any abnormal visual behavior. As an ophthalmologist, we should always take the parent's concern or the complaint seriously. Therefore, a thorough examination is a must. We should look for fixation behavior, any fixation preference, visual acuity appropriate for the age should be done. Always look for the red reflex, and a dilated refraction and peripheral retina examination is a must. In case we see any neurological disease, the child should be referred to the pediatric neurologist. About 6% of children less than 1 year of age present with significant refractive disorder. Therefore, the most common hyperopia and anisometropia are at greater risk of developing strabismus and amblyopia. Therefore, accurate refraction under cycloplegia is a must. In presence of esotropia, atropine refraction should be done. In infants who don't present with squint but has come for a general examination, either we can use atropine or cyclopentolate at a lower dose to prevent toxicity. In children over 2 years of age, we can use cyclopentolate 1% or hometropine. Now to the correction of refractive errors. In case the child has hyperopia at presentation with esotropia, full correction under cycloplegia should be the rule. We should always check the deviation in distant and near gaze so that we can rule out any convergence excess. If there is increased esotropia on down gaze, bifocal should be prescribed. In absence of squint or esotropia, the infants who are showing hypermetropic refraction should have regular monitoring every 4 to 6 months. Children more than 3 years of age who show hyperopia more than 4 diopters but still have a normal visual acuity should be given glasses to avoid asthenopic symptoms. In case of anisometropia of more than 2.5 diopters, correction is a must. If they have associated amblyopia, the correction should be given even for a difference of 1 diopter, as these are at higher risk of developing squint and amblyopia. In infants with astigmatism, more than 3 diopters should be corrected. For children more than 2 years of age, the astigmatism of 2 diopters should be corrected. In case the child has an oblique astigmatism, we should consider the correction for even a difference of more than 1 diopter. What is recommended in the AAO guidelines is that infants should be corrected for myopia of more than 5 diopters because they use more of near vision rather than distant vision. But what I have seen over the time is that even if children have a myopia of around 2 diopters in an age of less than 1 year, we should give the correction because any visual blurring is a stimulus for abnormal growth of the eye. In children more than 2 years of age, we should correct for more than 3 diopters. In case the child has presented to you with a difference of more than 2 lines in between the 2 eyes, patching should be given. We can start patching at any age, earlier the better. Role of near activities along with patching should be emphasized. Before giving patching, we should always look for any latent manifest nystagmus on uniocular occlusion. If the child has any latent manifest nystagmus, penalization should be preferred over patching in such cases. Majority of the ophthalmologists follow the full-time patching according to the age rule. What I prefer is part-time patching for mild and moderate amblyopia and full-time patching in case of severe or strabismic amblyopia. Part-time patching is done according to the age rule and the follow-up should be done depending upon the patient's age. One should stop occlusion when the visual acuity is equal in both eyes or the child alternates fixation and there is no visual improvement after 3 to 6 months of occlusion with good compliance. Strabismus is also commonly associated with neurological diseases like cerebral palsy and craniofacial deformities. Therefore, such children should have regular follow-ups every 4 to 6 months for refraction and peripheral retinal examination. They should also be given vision therapy along with occupational therapy for learning and reading disabilities. We also see commonly strabismus associated in cases of children with optic atrophy due to birth asphyxia, periventricular leukomalacia, or secondary to infections like meningitis. So we should not only judge them by distant acuity alone. We should always check for the near vision as they can do the near activities well. So we should give the best correction along with visual stimulation exercises and occupational therapy. So this needs a team approach and we involve the role of all pediatricians, ophthalmologists, teachers, nurses, everybody is involved in the management of such kids. To conclude, it is advisable to examine every child by 3 years of age to find any hidden eye disease. The C by 3 is the protocol which is followed by the American Association of Pediatric Ophthalmology. Whenever the child is diagnosed with a disorder, follow up every 6 months till 6 to 8 years of age and then 1 yearly. Any premature child or any child at any other associated risk factor should get an eye checkup at 1 month, 4 months and 1 year after birth. Thank you.